Good evening, everyone. Welcome you all for the IPNA endorsed webmaster series 2021. Now we are into the webinar 10, and the highlight of this program is we had been having polling sessions right from the beginning, and we have already done with 6 polling sessions. And this program has been extending from May 22nd to July 14th. So today we have two eminent speakers, Dr. Joseph Flynn and Dr. Mehul Shah. Dr. Joseph Flynn, who is the authority of hypertension, and we are so proud to have him, and we are too happy to have him as a speaker for our program. And this session is completely moderated by Dr. Rupesh, Raina.
Okay. Thank you, Dr. Ganesh, and thanks a lot.
Yeah, Dr. Rupesh Raina is adult cum pediatric kidney disease and hypertension nephrologist at Akron Children's Hospital. And he is also associate professor at NeoMed Medical University and Case Western Reserve University of Cleveland. And he is a representative of Pediatric Education Committee member for the ISN. And he is a fellow of National Kidney Foundation and American Society of Nephrology. And he also serves the National Kidney Foundation Advisory Board. And his area of his interest towards transition of adolescent with chronic renal disease to adulthood and many other things. Over to Dr. Rupesh to moderate the session.
Thank you, Dr. Ganesh. And first of all, I want to congratulate you for such an excellent webinar series we had last year, a lot of success in the setting of COVID-19. Today is a tough task that was given to me to introduce two giants in the pediatric nephrology. One is Dr. Shah, who I know him, has established the pediatric nephrology in Hyderabad, and Dr. Flynn, as I mentioned in my tweet, he's the world expert of hypertension. It's my pleasure and honor to invite the first speaker and give an introduction. That is Dr. Shah. Dr. Shah is MD in pediatrics, and he's also has done the fellowship in pediatric nephrology. As I mentioned before, he has established pediatric nephrology in the southern part of the India, basically in Hyderabad, and I had a pleasure to attend his facility and his when he hosted the ISPN Congress in 2017. Dr. Shah is a consultant pediatric nephrology in Apollo Health City, which is a very big corporate hospital with a lot of academic acumen, and he's head of the Little Star Children's Hospital, Hyderabad. Dr. Mehul Shah has an eminent interest in education and developing a new pediatric nephrology, and as such a pediatric nephrology interest in Hyderabad. His special interest for the research is in renal tubular disorder, antenatal renal anomalies. With that, I will give the podium to Dr. Shah for his talk today.
Thank you so much, Dr. Raina, for the kind words. And thank you, Dr. Namarwagaru, as well as Dr. Kalaivani for the kind invitation. I think the topic for discussion is infection-related glomerulonephritis. Over the next 30 to 35 minutes, I would like to start with a case presentation, followed by pathology as well as pathogenesis of post-infectious, specifically post-Streptococcal glomerulonephritis, outcome of post-infectious AGN, and my own experience taking care of some of the severe forms of post-Streptococcal acute nephritis in Hyderabad. Let me begin with this young 11 years girl who presented 17 years ago to me with initial severe oliguric ARF due to post-Streptococcal acute nephritis. She had low serum C3 and she was referred to me for dialysis. Her peak serum creatinine was 9.1 milligrams per deciliter. Next day, as I was planning for a biopsy, she started having spontaneous improvement. And over the course of next 6 days, the serum creatinine plummeted to 1.4 milligram per deciliter on her own. Over the next 1 week, she had a slow increase in serum creatinine from 1.4 to 1.7 milligram per deciliter. And that's when I did a biopsy, which showed crescentic glomerulonephritis with 95% crescents. There were no features of MPGN on light microscopy, and immunofluorescence had the typical dense capillary wall C3C and IgG deposits, what we call as the Garland pattern of C3 deposits. She was treated with IV steroids in the 3rd week, along with IV monthly cyclophosphamide and MMF and daily and steroids for maintenance. She had have a partial response. Her creatinine remained stable at 1.3 milligram per deciliter at 6 months, which was still quite high for a 11 years girl. At 7 years follow-up, her serum creatinine was 1.6 milligram per deciliter, giving her a CKD stage 3 of eGFR of 52 mL per minute. Unfortunately, 3 years later, the family discontinued all medications. She reached end-stage renal disease and she expired. So what I learned from this case 17 years ago was that post-streptococcal glomerulonephritis can present with rapidly progressive renal failure and severe AKI. I feel I should have performed the kidney biopsy earlier despite her spontaneous recovery, although she was non-oliguric from day 2 and she did not require dialysis, and I should have initiated treatment with steroids earlier to minimize inflammation and scarring. Until then, the teaching was that all cases of post-streptococcal glomerulonephritis will resolve spontaneously and we do not need to be aggressive. So what I learned in 2004 was that not all cases of post-streptococcal glomerulonephritis are benign. As early as 17th century, physicians recognized that the edematous swelling and dark and suppressed urine was a feared complication of convalescent period of scarlet fever. So something about post-infectious glomerulonephritis was thought to have been present for the past 4 centuries. However, it was in 1836 when Richard Bright first correlated infection and kidney disease. In 1959, it was David Earle and Robert Jennings who coined the term post-streptococcal glomerulonephritis when it was believed that streptococcal infection was the most common infection preceding acute nephritis. Following this, 2 decades of comprehensive picture of histology was apparent. By 1990s, it was apparent that organisms besides group A streptococci can cause post-infectious glomerulonephritis, and hence the more generic term of post-infectious GN rather than post-streptococcal GN. Since some of the cases of acute nephritis do occur concomitant to infection, the current terminology is infection-related glomerulonephritis, which does include post-infectious GN, staph-related GN, and IgA nephropathy as well. As we all know, acute nephritis is a pathological description of inflammation and/or cellular proliferation of the glomerulus. It could be either immune-mediated or it could be related to an immune disorder. It is acute glomerulonephritis which leads to the clinical syndrome of acute nephritic syndrome. As we all know, it includes hematuria, either gross or microscopic, hypertension, and variable degree of renal impairment. Proteinuria from mild to nephrotic range is often present with the above 3 parameters. PIAGN can follow multiple infectious agents. Of this, post-streptococcal glomerulonephritis is the most extensively characterized and prototype for PIGN because streptococcal infection is very easy to diagnose and confirm. It does remain an important cause of AKI in children of developing countries. Clinical features and outcomes of non-streptococcal cases of PIGN are similar to PSGN. In 2015, Richard Glaxock et al. Introduced the term IRGN, of which there are 3 broad categories. First, the post-infectious glomerulonephritis, which includes infection preceding glomerulonephritis. There has to be a latent period after resolution of the infection, which could be from days to weeks, following which development of glomerulonephritis. So infection followed by latency, followed by glomerulonephritis. In most cases, it is self-limited, and post-streptococcal acute glomerulonephritis is the prototype of post-infectious GN. The second group is the typical IRGN, where it is the ongoing infection which causes glomerulonephritis. There is no latency, and aggressive treatment of infection can often resolve glomerulonephritis. In fact, steroids may be detrimental in children with IRGN associated with ongoing infection. Some examples of typical IRGN include Staphylococcus-related glomerulonephritis, shunt nephritis, hepatitis B and hepatitis C virus-associated infection. And the third variety is the synpharyngitic glomerulonephritis. In this situation, glomerulonephritis occurs concurrently with pharyngeal infections, often viral as compared to bacterial infections with PIGN and IRGN. Often there is no latent period or a latency of just few days, maybe 1 or 2 days. This synpharyngeal glomerulonephritis is often an acute flare of an established disease for which kidney biopsy is often required for confirmation along with long-term treatment. And few examples of synpharyngeal glomerulonephritis would be IgA nephropathy and C3 glomerulopathy. Our focus is going to be on post-streptococcal acute glomerulonephritis over the next 20 minutes. We all know that different strains of group A streptococci cause post-streptococcal glomerulonephritis and rheumatic fever. There are different strains which causes this to non-suppurative complication. The actual incidence is very difficult to ascertain as a large percentage of these cases are subclinical. However, it is estimated that about 500,000 cases of PSGN occur worldwide per year. 1% of this leads to death in children with severe post-streptococcal glomerulonephritis. Unfortunately, most of the burden of post-streptococcal glomerulonephritis is in our developing countries. We are aware about the seasonal pattern of variation. Pharyngitis often occurring in winter season giving rise to post-streptococcal GN, and pyoderma developing in summer season giving rise to post-streptococcal glomerulonephritis. Studies of clinical and biopsy data indicate the prevalence of post-streptococcal GN to have reduced across the world, especially in developed countries. In contrast, in a developing country like India, the prevalence has in fact increased over the last 3 to 4 decades from about 7 to 10 per 100,000 population. Again, please understand this is a highly underestimated number since most cases of PSGN are either mild or they are asymptomatic, and they account for 5 to 20-fold the number of cases which have been reported over here. So PSGN remains a major cause of AKI in developing countries due to a number of factors, including overcrowding, poor sanitation, and unhygienic conditions, which give rise to frequent streptococcal infections in our children. Often there is delayed diagnosis and treatment, which allows a higher bacterial load to be present. Malnutrition and impaired immunity. Consumption of unpasteurized milk from cows with mastitis can predispose to infection with Streptococcus zooepidemicus. And finally, inadequate fluorination of drinking water is also a risk factor for streptococcal infections. The pathogenesis of PSGN is still not fully elucidated. Partly it is because of difficulty in developing an animal model, and because humans are the only host and reservoir for group A streptococci. Having said that, we do agree that it is an immune complex mediated glomerulonephritis, and the present evidence shows that there is deposition of immune complexes within the glomerular tufts and subsequent inflammatory response. Out of a number of antigens and proteins which are secreted by group A streptococci, there are 2 inciting antigens which has been found to be associated with PSGN. One is the streptococcal pyrogenic toxin B, also called as the nephritis strain associated protein NSAP, and the other is the nephritis associated plasmin receptor, which is a glycolytic enzyme and has multiple properties, including plasmin binding, assisting deposition of immune complex in the glomerular basement membrane, and also direct activation of serum C3. And this has been detected and proven based on the detection of antigens along with C3c in situ by immunohistochemistry, as well as detection of antibodies to both these antigens, both during the acute phase as well as the convalescent phase. This is a pictorial description of the pathogenesis. Let me spend a few minutes over here. As we know, the two antigens secreted by the nephritogenic strains of group A streptococci, that is the Streptococcus pyrogenic exotoxin B, as well as the nephritogenic associated plasmin receptor. Both of them are cationic in nature, meaning they carry negative charges. Sorry about that. don't know why I went back, are negatively charged and hence are repelled by the negatively charged anions present on the glomerular basement membrane. The plasmin or plasminogen, which is bound to this circulating antigens, helps in cleavage of latent metalloproteinases as well as procollagenase, secreting the active enzymes, which then removes the negative charges from the glomerular basement membrane, allowing the entry of the nephritogenetic antigen through the glomerular basement membrane into the subepithelial space, where they activate the inflammatory cascade by cleaving C3 component of the alternate complement pathway. Damage to the podocyte food processes allows the leakage of protein, plus the damage to the glomerular basement membrane allows leakage of RBCs into the Bowman space. Why do only some children develop AGN? Why not all children who are exposed to nephritogenetic strain develop AGN? The inflammatory response to acute infection is variable, and it depends upon amount of group A streptococcal antigen, the duration of its presence, as well as the host response. So there are multiple factors why some children get mild disease, some children get asymptomatic disease, and some children get severe disease. Similarly, the pathology is also quite variable. Most often we see a diffuse endocapillary proliferation. Sometimes we see with crescent formation, sometimes with only mild mesangial proliferation, and very rarely MPGN pattern on light microscopy. Immunofluorescence study will show us three patterns. The classic is the typical starry sky appearance of mesangial and glomerular basement membrane deposits of the C3C and IgG seen during the acute phase. During the resolution phase, it is only mild mesangial deposits. There is not much of capillary wall deposits. And the third variety, which is the capillary wall, the dense capillary wall deposits of C3C without any mesangial deposits, so-called the Garland variety of immunofluorescence, is seen in children who have got severe presentation and often is associated with massive proteinuria and poor prognosis. We are all familiar with the electron microscopic findings. It's usually characterized by subepithelial humps, mesangial and endocapillary cell proliferation. What are the clinical features of post-streptococcal GN? We can divide them into four types. The first is the typical acute nephritic syndrome seen in majority of children. The second is acute nephrotic syndrome, where there is combination of nephrotic presentation along with the AGN. Third is rapidly progressive renal failure with or without crescentic GN, which is present in about 2 to 4% of children with PSGN. And lastly, asymptomatic post-streptococcal GN, which is a major component of children with PSGN. The typical clinical features of post-streptococcal GN may start anywhere from 1 to 2 weeks following strep pharyngitis or 2 to 6 weeks following streptococcal skin infections. Children often present with gross hematuria, facial swelling, headaches, mainly as a manifestation of severe hypertension. These are the three typical presentations of children with PSGN. Occasionally, they may present with seizures because of hypertensive emergency, seen in about 5 to 10%. Sometimes it could be because of congestive cardiac failure and pulmonary edema, again seen in about 5 to 10%. And very rarely children may present with requirement of dialysis in a setting of oligoanuric acute renal failure. Let's go through some of the atypical features of post-streptococcal glomerulonephritis. The first one is one which has nephritic and nephrotic presentation. So in addition to the nephritic features, these children have not only nephrotic range proteinuria, but they also have hypoalbuminemia, serum albumin less than 2.5 grams per deciliter, with or without hyperlipidemia. It's not just the presence of nephrotic range proteinuria, but development of low serum albumin is important to defined nephritic nephrotic presentation. This usually indicates more severe inflammation with podocyte damage and is associated with garland pattern of C3C deposits on immunofluorescence. These children would often need treatment with steroids in order to minimize long-term morbidity, because this subgroup of children with PSGN has a potential for chronicity, and we'll come to this in the next few slides. The second atypical presentation of post-streptococcal GN is that with rapidly progressive renal failure, which is again uncommon but seen in about 2 to 5% of children. They present with oligoanuria, a rapid increase in serum creatinine, often associated with crescents on biopsy, and garland pattern of immune deposits. Again, this particular subtype of PSGN, like nephritic nephrotic presentation, has a high potential for chronicity unless treated aggressively. Besides these two, there are other atypical presentations. I would only enumerate them over here. Occasionally, we come across children who have got features of PSGN but minimal urinary abnormality. They are uncommon, seen in less than 5% of cases. They may present with edema or acute hypertension. They often have a low serum complement 3 level. Often, repeated urinalysis may be helpful to pick up few RBCs and mild proteinuria. A follow-up normalization of serum C3 after 2 to 3 months would retrospectively tell us that, yes, this was a child who had got post-streptococcal AGN with minimal urinary abnormalities. The second is post-streptococcal GN with a child who has got, HSP rash. We have had a couple of children with this. PSGN in children with IgA nephropathy. Again, there have been case reports about all these atypical presentations. And finally, recurrent PSGN, extremely rare and has been reported in less than 2% of children with post-streptococcal glomerulonephritis. It is a rare phenomena because of the long-lasting immunity against both the nephritic protein-associated plasmin receptor as well as the Streptococcus pyrogenic exotoxin B antigen, often lasting for 10 to 30 years. However, children with chronic recurrent upper respiratory tract infections, selective IgA deficiency, or lack of antibody response to these antigens may be at risk for recurrence of PSGN. In our own experience, we have had 3 children over the past 20 years who have had recurrent post-streptococcal glomerulonephritis. And this is one of the studies from Japan, which followed children with post-streptococcal glomerulonephritis over a period of 10 years. And as you can see, the anti-NAPR immunoglobulin G levels were above the protective value even 10 years after the follow-up. I am not going to spend a lot of time on diagnostic evaluation, but for the benefit of postgraduates, there are limited tests which are required, starting with complete urinalysis. It shows hematuria, microscopic hematuria in 95% of children with dysmorphic RBCs and RBC CARs. Often there is pyuria as part of the glomerular inflammation, and children are mistaken to have acute pyelonephritis when they present in the first 2-3 days of the illness. Proteinuria, often subnephrotic and occasionally in the nephrotic range. Obviously, some children will have deranged renal parameters. There may be mild dilutional anemia. Serum complement 3 is depressed in majority of children. We may have evidence of streptococcal infection in the recent past, either clinical or based upon rising ASO titer, or more specifically anti-DNase B titers. Ultrasound abdomen usually not required, but if done, is basically to rule out associated anatomical abnormality. So what could be the differential diagnosis of children with post-streptococcal glomerulonephritis? Children with low serum C3, as we all know, could have either PSGN or lupus nephritis, C3 glomerulopathy, infectious endocarditis associated GN, or D-HUS. These are the conditions which are associated with hypocomplementemia. However, if the serum complement level 3 is normal and the child has features of AGN, we need to keep in mind acute vasculitis or HSP nephritis or IgA nephropathy. Management is very simple, very effective. Most of them respond to supportive measures. Hypertension control requires IV or oral furosemide, depending upon the severity of edema, pulmonary congestion. Some children may require calcium channel blocker for about 10 to 14 days, along with salt and potassium restricted diet for the family for at least 2 months. I would like to emphasize that ACE inhibitors and ARBs should not be considered in children with PSGN for two reasons. One, the renin-angiotensin-aldosterone system is already suppressed because of volume expansion, and use of ACE inhibitors or ARBs would worsen the AKI by reducing GFR, and more importantly, will exacerbate the hyperkalemia. The management continues over here with use of oral antibiotic. This is not to alter the course of post-streptococcal glomerulonephritis in the index patient, but to eliminate the carrier state and reduce the risk of transmission to the siblings and other children. Rarely, children may require dialysis, anti-seizure medications, or steroids, depending upon their severity of presentation. The summary of typical clinical course of post-streptococcal glomerulonephritis is depicted over here. After a latency period, the acute phase lasts for about 7 to 14 days. Edema usually resolves by 3 to 7 days. Hypertension in most children resolves by the end of second week. Gross hematuria may last for about 3 weeks, but in most children, it resolves by 1 to 2 weeks. Proteinuria resolves by 3 months. Serum complement level usually normalizes by 2 months, but in most children by 3 months. And as we all know, microscopic hematuria may persist up to 2 years in children with post-streptococcal glomerulonephritis. So which children with PSGN would need kidney biopsy? Well, at presentation, if the child has rapidly progressive glomerulonephritis like picture or RPRF like my first patient of 2004, we need to do a biopsy to confirm PSGN and more importantly rule out other causes. Usually they will need therapy with steroids and long-term follow-up. The other subgroup of patients with PSGN who would need biopsy is those with nephrotic presentation. And finally, when there are typical features of PSGN but normal serum C3, are we missing some other diagnosis? So these are the three major indications when we would need to do biopsy in a child with PSGN. Children who do not normalize their serum C3 level by 3 months, we need to do a biopsy specifically to rule out C3 glomerulopathy. And if there is persistent active sediment in terms of proteinuria and hematuria at 3 months, or maybe even earlier at 1 to 2 months, to see if there is any severe glomerular inflammation and whether this children would benefit from therapy with corticosteroids. What is the outcome of children with PSGN? Well, as we all know, majority, they recover completely and they have excellent outcome, about 95%. Persistent urinary abnormalities is seen in only about 2 to 5%. But more importantly, we should be aware that there is a subgroup of children with PSGN who would end up having chronic kidney disease, including ESRD. What is the incidence is something which is not known in children. The typical PSGN, I think data from across the world have shown that most children do fine. However, from 0 to 14% of children may have persistent urinary abnormalities at long-term follow-up, and hence children after recovery from post-streptococcal GN should have at least an annual checkup for blood pressure and urinalysis, specifically to look for proteinuria. What about the outcome of severe PSGN in children? Not much of data has been reported. Let me begin with this data from adult population. Certainly PSGN in adults is known to have a poor prognosis with mortality of 0 to 36%, ESRD in 4 to 34%, and persistent urinary abnormality in up to 60% of adults with PSGN. So certainly children do have a good prognosis, not as unlike adults who do not have a favorable prognosis. There are very few studies reporting severity of PSGN and its prognosis. One of the earlier studies from our country was by Dr. Chug et al. From PGI Chandigarh, where it was a mixture of children and adults who had biopsy-proven post-streptococcal GN. 37% of 116 patients developed chronic renal failure at 10 years of follow-up, and that's 1/3 of 116 patients who had severe presentation. Although only 6% were children, but still 6%, that is 3 out of 51 children, had ESRD in the study reported more than 35 years ago. Their observation was that children with nephrotic syndrome, kidney failure, and crescents more than 30% were associated with poor prognosis. Few studies from Australia and from New Zealand. This was a study from Atkins et al. In 2001, where they found the risk of overproteinuria and post-streptococcal GN being 6 times greater than that of healthy controls. Again, please understand that this was a group of Aboriginal children in Australia who unfortunately are impoverished, and they belong to the lower strata as compared to the affluent class in the Australian population. So PSGN may be an important cause of ESRD in high-risk population is what was the conclusion of this study. And this study by Dr. William Wong et al. From New Zealand reported 27 children of mixed origin with severe PSGN who had kidney biopsy. 80% had AKI stage 3, 65% had nephrotic range proteinuria, 60% had crescentic glomerulonephritis. That means all of them have very severe presentation, and they had an average of 3 years of follow-up in 18 children. And their observation, 45% of the children ended up having chronic kidney disease. They were not able to clearly define the efficacy of immunosuppressive therapy, which was used in 15 patients. But of important to note is that 45% of these children had CKD at 3.2 years of follow-up. So what are the factors associated with poor prognosis? In children, we can say rapidly progressive renal failure, those with nephrotic presentation, those presenting late and often with delayed treatment are at risk for progressive chronic kidney disease. Based on histopathology, presence of garland pattern of C3C deposits is often associated with heavy proteinuria, extensive subepithelial hump deposition on EM, and crescent formation are some of the pathological findings which may be associated with poor outcome. Over the next 5 minutes, I would like to share my experience of children with severe post-infectious AGN, where 40 patients with post-infectious GN, most of them were post-streptococcal. They were retrospectively evaluated over 7 years from 2004 to 2011. 33% had severe AKI at presentation. 50% had crescentic glomerulonephritis. 7 out of 19 had nephrotic presentation, and 45% had only nephrotic presentation. So this is the group of children who had severe post-streptococcal glomerulonephritis. There were 3 children who had associated kidney disease, including HSP in 2, nephrotic syndrome in 1. One of the 3 children with recurrent PSGN had a biopsy, and 3 children had underlying chronic kidney disease, on top of which they developed PSGN. After my first patient, I treated all children with corticosteroids. In fact, 38 out of 40 were treated with IV methylprednisolone followed by oral steroids, with average duration of steroids being 6 months. 6 out of 40, 15% required additional agents, including MMF and cyclophosphamide. 8 children were on dialysis, 4 on PD because of the chronic kidney disease, and 4 required hemodialysis. What was the outcome in my group? 3 children with ESRD died while on dialysis, including first patient who had delayed treatment. 2 had progression of underlying disease to ESRD. They had chronic tubulointerstitial nephritis as their primary diagnosis. 35 of 40 children who had been treated with steroids have remained completely healthy without any urinary abnormalities, nor hypertension, nor elevated serum creatinine, and they have had minimum of 4 years of follow-up, and they have actually more than 10 years of follow-up in most of them at present. So my experience with the 3 patients who reached ESRD were, the first one, as I mentioned, I delayed the biopsy and treatment until the 4th week because the child had spontaneous recovery. She had a slow progression to ESRD and died 10 years later. The second patient presented to me at 2 months after onset with headache and active urinary sediment, creatinine of 5.6, and at 2 months when I did a biopsy, she had 100% cellular crescents, Garland pattern of immunofluorescence, no features of chronicity. She did not respond to medication and she was on dialysis for 1 year and we lost her. And the third patient presented with AGN to another hospital, was treated supportively despite the RPRF pattern. 1 month later, she had 75% cellular crescents, features of chronicity, was on dialysis for 6 months and expired. So all these 3 patients had severe RPRF, either because of no or delayed treatment, they progressed to ESRD and we lost them. So common features were severe AKI, RPRF pattern, delayed biopsy, or delayed or no treatment are risk factors for children to progress to end-stage renal disease. So my observation was that early and aggressive treatment of severe PI-AGN in children will decrease the risk of CKD as well as the incidence of chronic glomerulonephritis, which are often seen by our internist nephrologist. And final few slides about infection-associated glomerulonephritis in children. So far, I was speaking on post-streptococcal glomerulonephritis as a prototype of PIGN. Few slides on infection-associated glomerulonephritis. They are very rare in children. 3 major conditions are infective endocarditis, shunt nephritis, which is very rare now because ventricular atrial shunts are not put, hepatitis virus-associated membranous glomerulonephropathy, or MPGN pattern, or mesangial proliferative nephritis. Again, they are rare, but the bacterial infections are often associated with Staphylococcus aureus in 70% and other bacteria. Treatment is of underlying etiology. Prognosis, often not so good. CKD in 20% and death in 10%. And finally, IRGN with IgA deposits. This is something new. It's again a rare disease, but there are increasing reports more so in adult patients who have got comorbidities like diabetes, hypertension, coronary artery disease, often associated with staphylococcal infections in 70 to 80%. Site of infection could be the bones, the joints, the skin, the portacates, processes, or endocarditis. They often present late or with severe AKI. Biopsy often shows a dominant IgA deposits or codominant with C3C deposits. Treatment is usually supportive. There is no role of corticosteroids. In fact, corticosteroids may worsen the infection and push the patient to sepsis and death. Prognosis is very, very unfavorable with risk of ESRD in up to 80% and risk of death in a quarter of these patients. And finally, Staphylococcus-associated GN is different from post-Staphylococcal glomerulonephritis. This is infection-associated GN due to Staphylococcus is different from post-Staphylococcus glomerulonephritis. Here, the glomerulonephritis occurs while infection is ongoing. It is not post-infectious. There is continued antibody production leading to immune complex formation and deposition, often with cryoglobulins. These patients often have IgA deposits along with C3 deposits. The clinical and therapeutic implications are there for us to understand and use. Prognosis is often guarded. So to summarize, post-streptococcal glomerulonephritis is the most common cause of AKI in developing countries. Most often the diagnosis is made clinically and treatment is conservative with good outcome in majority of children. However, post-streptococcal GN and atypical features such as nephrotic presentation, severe AKI, and RPRF pattern have poor outcome. Early biopsy and treatment with corticosteroids in atypical PSGN may improve the long-term outcome of these children. And finally, long-term follow-up of children with PSGN is essential since besides the above group, 2 to 10% children may have persistent urinary abnormalities and hypertension. I would like to stop over here and thank you for patient listening. Thank you.
Thank you, Dr. Shah. I think I talked to the moderator and we'll take the question and answers at the end.
Okay.
And then we'll do the poll if that's okay, right, Dr. Srinivasan?
Yes.
Excellent talk, Dr. Shah. Very, very enlightening and a lot of updates on the IPNA, which is always nice to learn. The second speaker it's my honor to welcome and introduce Dr. Joseph T. Flynn. Dr. Flynn is actually a Dr. Robert O. Hickman Endowed Chair in Pediatric Nephrology. He's a professor of pediatrics, University of Washington. He's editor-in-chief in pediatric nephrology. He's a chief division of nephrology, Seattle Children's Hospital. I don't think Dr. Flynn needs any introduction. He is the icon, the epitome of hypertension, and it's always nice to introduce him saying that he established the parameters and the concept of hypertension in pediatric world, which was very well known to adult. And he is the father of hypertension. And it's my honor and privilege to introduce Dr. Flynn. He's not only a professor in terms of what he has done and given to pediatric nephrology, he's a very good mentor. And whenever you go and seek any advice from him, it's a very honest opinion he gives. We all look upon him for his mentorship, his guidance, and we're very proud to have Dr. Flynn in Seattle and to lead the hypertension world in pediatric nephrology. Dr. Flynn.
Well, thank you for that introduction. Thank you for inviting me to participate in the course. I've been asked to talk about outpatient evaluation of childhood hypertension. And I've chosen to do this using a case-based approach, which I hope will make it more clinically relevant and hopefully a little bit more interesting. So let's get started. So we'll talk about the first patient. A 16-year-old boy has had elevated blood pressures documented on a few visits to the office. The average of the readings is about 142/82. His height and his weight are above the 97th percentile for age, so he has obesity. His father has hypertension, and his father is on antihypertensive medication. So in thinking about him, what's the most appropriate approach at this point? Should we, one, have the boy return for repeat blood pressure measurement in 6 months? Two, provide lifestyle counseling to increase his physical activity, lower his salt intake, and then repeat blood pressure in 6 months? Should we begin diagnostic evaluation for stage 2 hypertension? Or should we admit him to the hospital for immediate blood pressure reduction? Well, the answer is 3. We should begin diagnostic evaluation for stage 2 hypertension. So let's talk about the definition of hypertension in children. As you know, in adults, hypertension is defined based on the occurrence of heart attacks and strokes above certain blood pressure levels. In children, those things don't happen, so we have a statistical definition of hypertension based upon the distribution of blood pressures in healthy children. And so hypertension is defined as an average systolic or diastolic blood pressure greater than or equal to the 95th percentile for sex, age, and height on 3 or more occasions. And for teenagers greater than 13 years of age, we use a cut point of 130/80 to denote a hypertensive level of blood pressure. Elevated blood pressure is above the 90th percentile, but below the 95th. And for adolescents, it is greater than or equal to 120/80. And these are the definitions that come from the most recent American Academy of Pediatrics hypertension guideline, which I co-chaired back in 2017. And in the guideline, we have the blood pressure classification table shown here. So on the left-hand side are the categories for children between 1 and 13 years of age, from normal blood pressure up through stage 2 hypertension. And then on the right-hand side, the categories for children 13 years of age or greater, ranging from normal blood pressure to stage 2 hypertension. So that boy his blood pressure was 142/82, and that puts him at stage 2 hypertension based upon the elevated systolic blood pressure. So he goes on to have some diagnostic studies done. He has 24-hour ambulatory blood pressure monitoring performed, which demonstrates sustained hypertension with reduced blood pressure dipping. His urinalysis is normal. His creatinine is normal. He has an elevated random glucose. He has elevated triglycerides and LDL cholesterol. He has a low HDL cholesterol, so he has typical dyslipidemia you see in obesity. So let's just talk a little bit about ambulatory blood pressure monitoring. This is a procedure in which the patient wears a lightweight blood pressure monitor that takes the blood pressure at regular intervals over 24 hours, usually every 20 to 30 minutes. The readings are recorded on the device and later downloaded to a computer for analysis. The study is analyzed by comparing the patient's blood pressure to a set threshold value. There is equipment available for use in children, and the validity of the procedure has been confirmed in children. In the AAP guideline, the use of ambulatory blood pressure monitoring was endorsed in several clinical scenarios. So first, to confirm the diagnosis of hypertension after if there have been 3 high office blood pressure readings, and that is to differentiate between white coat or ambulatory hypertension. Second is to evaluate blood pressure patterns in high-risk conditions, such as children with coarctation of the aorta, diabetes, or chronic kidney disease. And then thirdly, to assess how well a patient is actually being treated, either in chronic kidney disease, the blood pressure goal, which is a 24-hour MAP below the 50th percentile, and then repeat ambulatory monitoring in any treated patient to make sure that they're at goal. Using ABPM and the office blood pressure, we can categorize patients into one of 4 groups. So normal blood pressure, if both the ambulatory and the office blood pressures are normal. Sustained or ambulatory hypertension, if the office blood pressure is high and the ambulatory blood pressure is high. White coat hypertension, if the office blood pressure is elevated, but the ambulatory blood pressure is normal. And then masked hypertension, if the office blood pressure is normal, but the ambulatory blood pressure is elevated. This is a tracing of a patient with white coat hypertension. There is a solid black line, which I hope you can see, that shows the threshold value, and then the other lines are the patient's blood pressures. And you can see that after the beginning, the blood pressures were all pretty much below normal. The nighttime is denoted by the shaded area. The blood pressure dropped, and then he had a few high readings the next day, but overall the readings were normal. And that's compared to ambulatory hypertension, where all the readings are above the threshold value throughout the daytime portion, and a few overnight as well. So, based upon the information we have so far, what do we think the most likely explanation is for hypertension in this boy? Is it, first of all, from excess dietary sodium intake? Is it primary hypertension based upon the fact that his father has hypertension? Is it because he has prediabetes? Or is it because he has obesity? Well, it's probably because he has obesity. As you know, obesity is associated with development of hypertension, and there are multiple mechanisms that explain the link between obesity and high blood pressure. So these are illustrated here, and you can see that in the middle are the major mechanisms, which is dysfunction of the sympathetic nervous system, activation of the renin-angiotensin-aldosterone system, direct pressure effects on the kidney, and then systemic inflammation and oxidative stress. And all of these things then lead to changes within the kidney that increase blood pressure. And I want to talk a little bit more in detail about leptin and leptin resistance as one of the mechanisms for hypertension and obesity. So as you know, leptin is a hormone that is produced by adipocytes. It normally feeds back to the brain and causes a feeling of satiety, which reduces food intake, and it increases thermogenesis. It also has an effect to stimulate renal sympathetic nervous activity. In obesity, for some yet as poorly understood reason, the normal effects of leptin are blocked, or people become resistant to the normal effects of leptin, and you have increased renal sympathetic nervous system activity leading to the hypertension. And then in the kidney, just want to talk a little bit more about what's going on. So there's compression in the renal medulla, increased activity of the renin-angiotensin system, leading to reabsorption of sodium and water, volume expansion, hypertension, and so forth. So what is the therapy for a patient like this who has obesity, hypertension? So first of all, we would acknowledge that ideally weight loss would be primary therapy, but it's very difficult to get patients to lose weight. We know that to be true. And so what we talk about in the guideline is that there are two lifestyle modifications that are preferred. First, increased physical activity. So the guideline recommends vigorous physical activity 3 to 5 days per week for 30 to 60 minutes per session. Should be aerobic exercise or perhaps a combination of aerobic exercise with resistance training. And what I like to do is to try to find an activity the child's already doing and then talk with them about how they could intensify that to meet our goal. The second part of the recommendation is nutritional counseling. So we provide diet on advice on the DASH diet. DASH is an acronym that stands for Dietary Approaches to Stopping Hypertension. The DASH eating plan includes increased intake of fruits and vegetables, as well as more low-fat dairy products, and then dietary sodium restriction. You can read all about it at the website dashdiet.org. And then at the same time, we acknowledge that the American Heart Association recommends reduced sodium intake to at least 2,300 milligrams per day, ideally 1,500 milligrams per day, which admittedly is quite difficult to achieve. And what's also very important to acknowledge is that a family-based intervention is going to improve success because, as you might imagine, it's not just the child who has obesity, it's not just the child who has hypertension. There are likely other family members as well who require the same intervention. So then what happened with this boy? So he met with our nutritionist who taught him about healthy eating, and he worked on reducing his sodium intake, reducing his snacking, trying to eat smaller portions at meal times. His father started taking him to the gym 4 days per week, and he used a treadmill and did some weight training. And over a 2-year period, he lost about 15 pounds, so a modest weight loss. His BMI dropped from above the 97th percentile to the 93rd percentile. So still elevated, but improved, and his blood pressure fell down to the elevated BP category from the stage 2 hypertension category. And this is actually a real patient that I saw a few months ago. I did not make this up. Every so often, we do come across a patient who is able to carry out the lifestyle change, and we do see that that works. All right, so let's move on to the next patient. This is a young boy, 5 years old, who comes into his primary care provider for a routine well-child visit. He has not been seen in over 2 years. Blood pressures are elevated, 137/85, 129/90, and they're confirmed to be that high by manual readings. So what do we do about a patient like this? Well, the first thing we do is to repeat the elevated blood pressure readings. We know that blood pressure in childhood is quite labile. It can fluctuate widely, even in children with secondary forms of hypertension. So this is why the clinical practice guideline and every other guideline that's come out over the years leading up to ours recommends that at least 3 abnormal readings should be obtained on different occasions before you make the diagnosis of hypertension. And the other important point is that elevated blood pressures obtained using an automated oscillometric device should be confirmed by auscultation. So let's talk about blood pressure measurement devices for a minute. So possibilities are mercury column sphygmomanometers, aneroid sphygmomanometers, and then automated devices. So we don't favor automated devices for reasons I will talk about in a minute. And mercury column devices are not widely available any longer due to the occupational hazards of mercury. So, whoops, I'm not quite sure what's happening here. All right, so let's talk about the oscillometric devices. So they have their advantages. They're user-friendly. You put the cuff on and push a button. They can be repeated. They can be programmed to take repeated measurements, and this is probably their greatest advantage. The blood pressures are consistent once the device is accommodated to the patient and the patient's accommodated to the device. And you can often retrieve the readings or print them out for so you actually know what the readings are. Well, they have their problems. As you know, they're not measuring blood pressure. They're measuring the oscillations of the arterial wall as the cuff pressure is reduced. And from the amplitude of those oscillations, it estimates what the mean arterial pressure is, and then it back calculates the systolic and diastolic values. It is well known that oscillometric devices overestimate systolic blood pressure and underestimate diastolic blood pressure. And it's well known that the measurements are not the same between different brands of devices because the software is proprietary to each manufacturer. And you get what I basically refer to as an alerting response on the first reading because of how high the cuff inflates. So we are left with auscultation, and it's important to use the correct auscultatory technique. Patients should be seated with their back supported, feet on the floor, resting for at least 5 minutes before the blood pressure is measured. No talking, no use of the smartphone or any other activity. Make sure that you use the correct size cuff, and which we'll talk about, and repeat the readings at 1 minute intervals. And the American Academy of Pediatrics has actually produced a video illustrating the correct auscultatory technique in children, and you can go to this website, which I'll show again at the end, and see the correct technique illustrated. And then cuff size is very important. Probably the most common cause of inaccurate readings in children is the wrong cuff size. So we know that the manufacturer is going to say small adult or child on the cuff. But this may not be accurate because, especially in children who are overweight, they may need a larger size cuff. So the ideal thing, and what we do in our hypertension clinic, is we measure the child's arm circumference, and then we pick the right size cuff. And you have to have a variety of cuff sizes for different sized children. So let's get back to our 5-year-old boy. He actually has been having some headaches without other symptoms, but this has been going on for a while. He was a term baby. He had no neonatal complications, no prior hospitalizations or surgeries. He's not taking any medications or supplements. There is a family history of hypertension affecting his father, 3 out of his 4 grandparents, and his mother has type 2 diabetes. There is no family history of kidney disease. He has an examination, so his weight is above the 97th percentile, his height is normal, his body mass index is above the 97th percentile. The rest of examination is normal. There's absolutely nothing else wrong with him. So he is re-evaluated, comes to the hypertension clinic, blood pressures are repeated and they're high. The average is listed here. And in comparison to the cut points, which are the 90th, 95th, and 95th plus 12 listed here, he has stage 2 hypertension, again because of high systolic blood pressure. And so he has further workup done. Leg blood pressures are measured, and they are a little lower than the arm blood pressures. He has lab work done, some imaging ordered, and because he's symptomatic, he started on treatment at the first appointment. And we chose propranolol because in the United States, propranolol is commercially available as a liquid. His urinalysis is normal, his creatinine is normal, normal electrolytes, his renin is high. He has an echo done, his heart is normal, but there's some left ventricular hypertrophy. His kidney ultrasound is done, and the kidneys are normal appearing and normal size bilaterally. And then he was sent for a CT angiogram of the abdomen. And the pictures are shown here, and I'll just show you I'll highlight the areas of interest. So you can see here in the upper abdominal aorta, he has a very narrowed aorta. You can see that in this image and in the 3D reconstruction over here. And actually, he had bilateral renal artery stenosis as well as a narrowed abdominal aorta. So he has mid-aortic syndrome. So why did we do those imaging studies? So if we go back to the guideline, it talks about how to image. And so you might be wondering, why didn't we do a Doppler ultrasound in this boy? So actually, Doppler ultrasonography is only recommended in older children and in normal weight children. And that's because its sensitivity and specificity in younger children and children who are overweight is poor compared to arteriograms. And so the alternative recommended imaging is a CT angiogram or a magnetic resonance angiogram, and which you do probably depends on what's available at your center. At our center, we do CT angiograms. We find that the magnetic resonance angiograms have too many false positives. And are we surprised that he has secondary hypertension? Absolutely not. These data come from a analysis of children enrolled in 2 trials of a blood pressure medication, and they were divided up into primary hypertension on the left, secondary hypertension on the right, and the blue bars are children less than 6, and you can see that the children in the blue bars, or in a younger age group, mostly had secondary forms of hypertension, whereas children over 6 had primary hypertension. And so also in the guideline, we say that children and adolescents who are greater than 6 do not require an evaluation for secondary causes, especially if they have a positive family history of hypertension, if they're overweight, and if there's no history of physical exam findings suggestive of a secondary cause. So what happened with this boy? Well, he needed to have amlodipine added to his propranolol to control his blood pressure. He did have a repeat echocardiogram a few months later that showed improvement in his left ventricular hypertrophy. He was considered to be a little too small to undergo surgical correction, so we just kept him on medical therapy and repeated kidney ultrasounds to monitor the growth of his kidneys. And then eventually, when he was older and bigger, he underwent surgical reconstruction of his abdominal aorta and reimplantation of both renal arteries. A 15-hour surgery. He's off his blood pressure medications later, but still being followed closely. So let's talk about the third case, which is an athlete. This is a 14-year-old girl who goes out for the soccer team, has her blood pressure checked at a screening event, and it's high. And the readings are listed here, 137 to 149 over 75 to 80. Comes in for follow-up, and the office blood pressures are the same. She has no symptoms. She's at the 50th percentile for height and weight, so she's slender and athletic. She has no other chronic health problems. She has no abnormal findings on her physical exam. Both of her parents have hypertension. So what do? Do we, number 1, start her on hydrochlorothiazide? Do we, number 2, refer her to interventional radiology for an arteriogram? Do we perform ambulatory blood pressure monitoring? Or do we have her go back to the school nurse for follow-up blood pressures? Well, you heard the first part of my talk, so of course we're going to do 24-hour ambulatory blood pressure monitoring as the next step. And so she had 24-hour ambulatory blood pressure monitoring, which demonstrated sustained ambulatory hypertension with normal dipping. She has a urinalysis, lab work, everything's normal. She had a lipid profile, everything normal. So then what do we do? What is her diagnosis? Does she have metabolic syndrome, primary hypertension? Does she have renal artery stenosis? Does she have polycystic kidney disease? Remember, her blood pressures are at the stage 2 level. Well, as you saw in that graph I showed you a few moments ago, most likely she has primary hypertension based upon her age, based upon the positive family history of hypertension. So we have to think about how she's going to be treated. So management of hypertension includes 3 components, including non-pharmacologic measures, which we've already talked about, blood pressure medications, and then ongoing monitoring. The indications for antihypertensive drug therapy are symptomatic hypertension, like in that young boy that I presented, secondary hypertension, children with hypertensive target organ damage, children with diabetes, those who have persistent hypertension despite non-pharmacologic measures, and those with stage 2 hypertension if there's no modifiable factor. And this is where this girl, we have to think about medications for her. What is the goal? So in the guideline, the goal for treatment, whether it's non-pharmacologic or pharmacologic, should be reduction in systolic and diastolic blood pressure to less than the 90th percentile or less than 130/80 in an adolescent. And in children or adolescents who have chronic kidney disease and hypertension, we actually have a goal based on ambulatory blood pressure monitoring to get below the 24-hour MAC below the 50th percentile. How should we prescribe blood pressure medications in children? Well, we feel that only drugs that have published pediatric efficacy and safety data should be prescribed. And if you look in UpToDate or whatever reference you use for drugs, many antihypertensive agents do have pediatric dosing recommendations. We use the stepped care approach, which is illustrated in this graphic. So you start with the initial dose of your drug that you've chosen. You increase that until you get the patient to their desired blood pressure, or you get to the maximum dose of that drug. If your blood pressure is still not controlled, you add another medication, usually with a complementary mechanism of action. If you still don't have a blood pressure under control, you should add a third drug, or at this point, especially if you're in a primary care setting, you would probably want to send the patient to somebody who's more experienced than you in treating hypertension. And the one thing I like to state is that it is not unusual to need more than one medication. And most of my, or well, I'll say many of my patients with primary hypertension are on 2 drugs because we cannot get their blood pressure down with just one medication. Now, what about this girl? She wants to play soccer, right? So what do we do with her? So we look at the guideline again, and it says that children who are hypertensive may participate in sports once they've been evaluated for hypertensive target organ damage and their cardiovascular risk has been assessed. And that they should receive treatment to lower their blood pressure below the stage 2 threshold before you allow them to compete. And we look at the sport that they're in, and this graphic looks at the static component versus a dynamic component, and sports that have a more static component are at a higher cardiovascular risk than those that are more dynamic. So, for example, bodybuilding is more static compared to volleyball here. And so we sort of put all that together to figure out what the right course of action is for each child. So what is her outcome? Her blood pressures were at the stage 2 level. So we told her that she could do some light workouts with the team, but she could not compete. She had an echocardiogram done. She had a normal ejection fraction. She had mild concentric left ventricular hypertrophy. So she was started on treatment with amlodipine. We had to go up to the maximum dose, and we used home blood pressure monitoring to see whether we were at goal. She came back, and her blood pressure got down to 132/78, which is at the stage 1 level. So now she's allowed to compete. And so that's what we would do with a patient like that. Now, that's pretty much the end. Here's where you should take a screenshot. So here are the 3 things that you might want to go back to. The clinical practice guideline, the AAP video on blood pressure measurement, and then the ambulatory blood pressure monitoring statement. All of these things are freely available online. And with that, I thank you for your attention, and I'd be happy to take questions if we have time.
Thank you, Dr. Flynn. And thank you, Dr. Shah. We have a lot of list of questions available. I'll pick up what you kind of relevant with the short time commitment I have. So for Dr. Shah, I'll start with you. A question: there is a patient who has an HIV positive, came in with COVID positive PCR, developed AKI pancreatitis, low C2C4, nephrotic range proteinuria. After 7 sessions of hemodialysis with AKI got resolved and proteinuria decreased to nephritic range after 3 weeks. Complement level normalized, hypertension persists, but controlled on on amlodipine. Should we do renal biopsy or should we wait? So it's a little bit of confounded there. Like patient is have an HIV immunosuppressed, coming with COVID-19 with nephrotic range proteinuria and low complements, which could be a multitude of factors there. So they got better, patient has to go for hemodialysis, and then the complements got better over the time after the hemodialysis. So they're asking, the proteinuria got better too, whether they should biopsy the patient or not. Dr. Shah?
Mehul sir, you're there?
That's okay, but I can take this question because I have a lot of cases in the COVID-19, and basically I've seen now a lot of trending on the MISC. We have seen hematuria and proteinuria in the setting of COVID-19 infection, and it persists about like 6 to 7 months. And the kids, I have yet to see a COVID-19 with HIV, but I have certain kids who have hematuria, proteinuria. Most of the time in this adults, we have 2 cases have a nephrotic range proteinuria, and one of them came out positive for APL1 gene. And with all the research that I did in COVID-19 AKI in adult, it is definitely a podocytopathy. The virus has been identified in the podocyte. It also causes the rapidly progressing FSGS or collapsing FSGS sometime too in the setting. So there was a lot of confounders there in this setting. I don't know what to make out of the complements that C3, C4 were low and then they normalizes. I think the patient has a lot of confounders here. The COVID-19, the chemokine burst in response definitely could be disastrous and confounders here. Most of the time what we have done, I've done like in 2 kids so far, that we use high flow CRRT, but in adults we have used Auxeris, which is an extracorporeal adsorbent, which has been used and you can use in the CRRT. These kind of a setting, I will definitely do that within 48 hours with multisystem organ failure and pancreatitis. So this is a pretty interesting question on COVID-19 emerging. And as a pediatrician, we should all know about extracorporeal therapies now. It's soon going to be very much prevalent with Auxeris on board, Cytosorb on board. We may be using these now in the setting of sepsis. And I feel like that pediatric nephrologists are not very much in tune in US at least, and I'm sure in India too, for these kind of extracorporeal adsorption therapy. So that I answered, Dr. Shah, I answered your question on that.
Absolutely. I'm sure I would have not been able to answer that. I have no experience. Thank you so much, Dr. Raina. Thank you.
Yeah. So another question for you too, and both Dr. Flynn and Dr. Shah can answer is, can dexamethasone be as beneficial as methylprednisone? I get this question all the time whenever I give a talk to in Asia or anywhere.
Yeah, I think yes, Dr. Flynn.
I mean, we've used dexamethasone as a alternative to prednisolone. Actually, we did it recently because there was a girl with chronic IgA nephropathy, and she hated the taste of the prednisone tablets and refused to take them. But dexamethasone was, of course, it's a lesser tablet burden, and it worked.
That's a very right answer. Dr. Shah, any input on that?
No, I think I agree with what Dr. Flynn has mentioned. In developing countries, dexamethasone is cheaper, so that could be an alternative. And it has a little longer biological half-life as compared to methylprednisolone, like 8 to 16 hours versus 30 to 36 hours. So I think that's the advantage. But I think, theoretically, yes, it should not be a problem. Cost-wise, it is more economical. Compliance definitely better because of longer biological half-life. But I think personally, and most studies have been reported with the use of methylprednisolone, but theoretically should not be an issue.
Okay, thank you. Another question for you, Dr. Shah, and I don't know in relevance to what the person who was asking question was pertaining to. His question is, thank you for your presentation, which I totally agree. Your presentation was great. Did you make another kidney biopsy before starting MMF or cyclosporin? What finding do you consider of deciding or to decide starting the second immunosuppression?
Yes, I think the answer to the first question, I think it's, I guess this is related to the first patient and the subsequent 6 patients where I used MMF or endorsed. Generally, MMF is used if there is persistent nephrotic range proteinuria, or if the serum creatinine has not improved in 4 to 5 weeks after initiation of methylprednisolone. So that is the reason if 1 month of IV followed by oral corticosteroids does not improve the renal parameters, or if the renal parameters have improved and there is persistence of nephrotic range proteinuria despite use of corticosteroids as well as ACE inhibitors, once the renal function is better, I end up adding another agent. I usually do not repeat the biopsy because the renal parameters have improved, and I don't see any reason to repeat a biopsy unless if the renal parameters have remained elevated, then I do the biopsy. But I did not have to do it in any of those remaining 35 patients. I did not.
Thank you, Dr. Shah. So now this question is for Dr. Flynn. Before I go to the question, I have this question from Dr. Flynn. It is always in my mind, and I'll put forth there. You know, it's very hard in the setting when we see the children's, I don't know, somehow in my area, I see obesity-related hypertension more, that we don't have any clinical on like bedside evaluation to see that there is any involvement of the what you call as the cardiovascular involvement. Sometimes we rely on left ventricular mass index, which also is kind of a debate with the cardiologist to tell them we don't need the LVH, we need LVMI. But there's a lot of data, and we looked into the CKID, which you are already aware. We did the ASI, and we looked into the pulse pressure and pulse pressure index. So mainly in the Asia and Japan, there is a lot of data coming out for pulse pressure indices, index, and then pulse pressure and ASI. Anything which you can give as a bedside evaluation with the blood pressure rather than going for a ABPM, which could just pertain us to, at this point of time, there is a cardiovascular involvement, or at least there is some kind of endothelial dysfunction going, and that could lead to long-term cardiovascular mortality and morbidity.
Yeah, I mean, there's a lot of advanced techniques that can be used. But right now they're all really research techniques.
Yeah, the question I have for you is, this is from the participant, and it's a very good question here. The question is, how long post-coactation repair does child hypertension resolve? And actually I have 2 cases. One is a very young girl that I saw in my office, and I'm kind of weaning off the medication now after it was a surgical repair. So this is a very pertinent question, and how long and what to assess after the coactation repair?
Well, so I would actually flip the question around, because the fixing the coarctation will fix the hypertension pretty immediately. But what the studies using ambulatory blood pressure monitoring have shown is that like 3/4 of these kids develop hypertension again, even without a gradient across their aorta, the repair. And and I think it's because they have abnormal blood vessels. And so we're seeing many of it's interesting. I mean, with this 2017 guideline, I think a lot of the cardiologists finally woke up to the fact that this is something important to look for. And we're getting more and more of these kids, usually they're teenagers. They have their coarc repair in infancy, and then they start doing the ambulatory blood pressure monitoring, you know, when they're teenagers, and then they're coming to us with recurrent hypertension. And it's very important to detect that, because in children with coarctation of the aorta, the long-term mortality risk is high, and probably the excess mortality is related to undiagnosed hypertension.
Very good point, because we are seeing, like, when I see some of the adolescent, not only with the coarctation, but even with any kind of congenital heart disease repair, and then they are evolving into adolescent. I've been doing a lot of ABPM, and actually the trend is now between 18 to 24. I do ABPM just to assess, and you're right, we pick up a lot of, and I saw them like lack of nocturnal dipping, which is very obvious in these kind of patients. And that just triggered me to say that there is something which is, and ASIs have been high. So that's a very good point, and nice question though. Then I have a very particular question that's very much specific to the attendee. Sorry, it's just kind of hard to move and navigate these slides. The question is about the renal artery stenosis, and they were asking about what interventional tests can be done if you have a renal Doppler that is consistent with an involvement of renal artery stenosis, and do we go for angiography, do we do CT angiogram, and what is the sensitivity and specificity in the Dopplers? And it's always an open question, Pete.
Yeah, I mean, the best, there was a recent paper, maybe it's about 2 years old. No, it came out in 2017 or 18 from Great Ormond Street, and they compared Doppler to arteriograms, and it's something like 70% sensitivity. And so at our center, we don't do Dopplers. So they go right to CT angiograms if we're concerned about renal artery stenosis. And we'll do it when we prove that the patient has it, and we can tell the technician where to look for it. We'll often do the Doppler in the follow-up of the patient after a balloon procedure. But for diagnostic purposes, we do a CT angiogram followed by an arteriogram.
And actually, that's a good data. And, you know, I've trained in Cleveland Clinic. And as you know, Dr. Flynn, the guru of the renal artery stenosis, Dr. Mark Paul, was my attending. And in adult, they have looked into the renal Doppler. And what we found out in our study, if you have, and I'm talking about adult, not insurance, if it's very operator dependent, first of all, if you have a stenosis more than 70%, then the sensitivity specificity is higher. And so it's very operator dependent, and definitely in insurance, it's better to do a CT angio. And I have one case, I was about to actually send you an email about it, but finally I got a CT angiogram and I found out that there is a mild stenosis with a renovascular hypertension, and that's very diagnostic. And we hardly see that in the kids with going into real stenosis that could be intervened, but this is something good. The last question is kind of very generic. I don't know, I should put you on the spot for that. The question is how to decide on what antihypertensive to start. And that's very subjective. It's very dependent on the patient. So I don't know, but if you have any general advice for picking up the different antihypertensive. And before I go there, I just want to let you know, everybody in the pediatrics, they get mad with me when I start the hydrochlorothiazide in an adolescent who is obese and has a high BMI, because a lot of the people don't go with the hydrochlorothiazide right away, and it's very hard to see whether it's salt sensitive or not. And some of these adolescents, they just melt on me for 12.5 of hydrochlorothiazide. And that's a very open-ended question, like what to start and what kind of antihypertensive we should pick.
Yeah, I mean, that's a long discussion, and, you know, I worry about the metabolic effects of diuretics in these kids with increased insulin resistance and so forth. And so our typical medication we use is lisinopril.
Thanks. I think that's the only question I have, and not have anything I could see. Let me refresh it. I think those are the main questions which I think was very pertinent. And I really like that COVID-19 case, and that is something evolving a lot. in the setting, and we are seeing even in MISC, I'm seeing hematuria and proteinuria, and I don't know, we got a lot of MISC cases in our hospital that came up with. So with that, I think I will give it to Kalyavani to close this session. I really want to personally thank Dr. Shah. It was nice seeing you virtually, Dr. Shah.
Thank you so much.
Thank you, Dr. Flynn. It's always, whenever I listen to your lecture, I always learn something, and always I take away some of the important points that will help me in my medical management. With that, I will give it to the Dr. Kalyavani.
Thank you so much, sir. Thank you for the wonderful presentation. I really appreciate the knowledge, the depth of knowledge in your talk. And it was exactly what we needed to hear. Thank you so much, Dr. Flynn. And thanks for sharing your knowledge, sir. Dr. Mehul Shah's talk was, as usual, all about clinical-oriented talk. It was exactly what we see on a day-to-day basis. Thank you so much, sir. Thanks for moderating the session, sir, Dr. Rupesh. And next, we'll be moving to the polling session. I think I should not make the speakers wait for the participants' sake. I think thank you so much. Have a good day, Dr. Flynn. Thank you, Mehul, sir. We'll be moving to the polling session.
Yeah, we'll send you the results of the polling later on, but it's not fair for Dr. Flynn and Dr. Shah to wait and look into the polls.
Thank you.
Thank you. Thanks a lot. Bye-bye.
Thank you.
Bye now.
Thank you so much, sir. Have a great day, sir. Bye, sir. Now we'll move ahead with the polling session. The instructions for the polling session are all participants are requested to enter their proper mail IDs for future communication. And now we are taking up the 6th polling session, and there is little change of dates in the polling session. The polling session, which was supposed to be conducted on 7th July, we have it on, on 26th of July. We have the next polling session on 26th of July. And the total duration is 8 minutes for the polling session. Probably we will extend it to 10 minutes because the questions are a little lengthier. And we have 3 star questions in each session, and the star questions are taken into consideration in case of a tie, and only trainees are allowed to participate in the polling session. Requested all participants to log in on time. We'll start the polling now.